Thank you very much.
Thank you. It's an honor to address such a distinguished group. Thank you for having me here, and thank you for the work you do in this field. I'm going to talk today about addiction treatment in two settings, in the healthcare system and in the criminal justice system. There we go. So these are some of the public health and public safety threats associated with substance use disorder. Dr. Posnick did an excellent job documenting the various diseases that are associated and injuries that are associated with substance use disorder. Let me just add one more consequence that is on this list, which is violence, particularly associated with alcohol and cocaine and drugs of that sort that seem to be criminogenic in their effects. For this reason, unlike with other diseases like cancer, a significant portion of people with these problems will come into contact with the criminal justice system, and that provides new opportunities to provide therapeutic services to them. By hand, yeah. Where? Over there? There we go. Okay. Sorry, a little technical problem there. Okay, so I'm going to talk about primary therapeutic options for people who have more severe disorders. In doing this, I'm limiting the discussion for the sake of time. There are people who have less severe disorders who can be helped with screening, brief intervention, as described by Professor Babor. There are also services that do not focus on changing substance use per se, like, for example, distributing naloxone or needle exchange, and I'm just going to focus on treatments just for the sake of time. But the book that Professor Babor mentioned, Drug Policy and Public Health, does cover all those interventions. So, there we go. In this class, I'm going to talk about two broad types of interventions: mutual help organizations or peer help organizations, also called self-help organizations, and professionally administered treatments. So, self-help organizations are an international phenomenon. Almost every nation, including Turkey, has organizations of people who have had problems with drugs and alcohol and come together to support people in their recovery. For example, I know in Turkey you have Alcoholics Anonymous, you have Narcotics Anonymous, and perhaps others. So do these organizations actually work? I'm going to show you two studies of this. The first is of an organization called Oxford House. They own properties where they live in a peer supportive setting, where the only rule is you may not engage in substance use, and they help each other try to recover. This is a study that was conducted by Dr. Leonard Jason, following people going through Oxford House who had very long histories of drug use and very long criminal histories over a 2-year period, and it was compared in a randomized trial with how they did in Oxford House versus other types of care. This chart shows the outcome. So the first outcome is abstinence, measured at 2 years. Oxford House is the orange bar, usual care is the bluish-green bar. As you can see, it's about almost twice as much abstinence in the Oxford House group. The second set of bars is employment, and again, much higher rates of keeping a job in the people in the self-help Oxford House setting. The last 2 bars is incarceration, returning to prison, and that's lower in Oxford House. In other words, when people were engaged in these peer self-help residential settings, they were less likely to return to crime and go back to prison. These are pretty impressive findings. Here's another trial, another randomized trial on the organizations Alcoholics Anonymous and Narcotics Anonymous, which I think many of you will know. This was done at my hospital, led by my colleague, Dr. Christine Timko. And in this study, patients who were already engaged in outpatient care were randomized either to a structured introduction to these self-help organizations or just a simple referral. In the structured introduction, they were told about the organizations and linked to someone who could take them to their first meeting. And what that showed was that if you did that more structured introduction, you got higher rates of involvement in self-help organizations and about 60% greater improvement on a measure called the Addiction Severity Index in terms of their alcohol and drug problems. These are very large effects from a self-help organization, again, in a randomized clinical trial, which is the most rigorous research assessment. Okay, let's look at cost. These peer self-help organizations are not professionally managed. They're run by people who are volunteers. As a result, they end up being a much less expensive way to help people maintain the recovery. This study is of people who went through inpatient professional treatment and were strongly encouraged to get involved in self-help and peer-led programs after treatment or not. And this chart shows you how much all their health care cost in the year after treatment. The blue bar is in the programs that didn't encourage self-help. The orange bar is in the programs that did. And what you can see is that the costs were substantially lower in the programs that connected people to self-help groups. After treatment, they needed less inpatient days back at the hospital and less outpatient care. And that top bar shows you this saved thousands and thousands of, those are American dollars, but the amount of money was about 40% less. Despite that, their outcomes were as good or better. So this is a way that the self-help peer system can extend the benefits of the formal healthcare system, help people recover in a way that is affordable. So now I'm going to move to professionally administered addiction treatments. These are programs that have staff, psychiatrists, psychologists, social workers, and counselors paid to help people recover from addiction. This is different than just detoxification, which is the management of a person who is acutely intoxicated, usually in the hospital, to just preserve their life and health for a few days. This is what comes after, the actual therapy. And there's sort of 4 broad classes of things you see in the field around drug addiction. First, there are the opiate agonist therapies for people who are addicted to opiates. So methadone maintenance is the one I think most people know. Opiate antagonist therapies are another type of medication. Naltrexone is the one most people know. It has a different mechanism of action, but the logic is similar in terms of engaging people and getting them on a medication while providing counseling. There's also a number of programs that are residential treatment or therapeutic communities where people actually live in the setting for extended periods and learn to stop using drugs and alcohol and also change many other aspects of their life. And then last, there are outpatient care models where people live at home and they come in for some type of counseling anywhere from once a week to many times a week. Do these treatments work, and what is their impact? Let's look at that. How much people change. Well, I'm going to introduce you to a rule I use, which is the about half rule. Like many of you, I've often asked, how much do people change in treatment? How many people become abstinent? How much does substance use drop? A very safe general rule is to say about half. In other words, if you look at a treatment study and the question is, what proportion of people after treatment will have stopped using drugs and alcohol? It's usually around half. Sometimes it's 40%, sometimes it's 60%. That's very, very good. If you compare that to other forms of health care, like, for example, cardiac surgery or cancer care, to have a recovery rate of about half is actually very good, especially for an inexpensive treatment. The other way to look at outcome is to say, instead of asking how many people are totally abstinent, how many people stop using particular types of substances. So in other words, if the sample was 80% using heroin, what it would be like afterwards. And again, the answer tends to be about half. If it's 80%, it drops to 40%. If it's 60%, it drops to 30%. I won't belabor this. I did write a paper that will be in the Sempozyumu book that comes out that goes into these studies. But just to say, this is found many, many times. It's about half of people showing pretty substantial benefit on substance use. Now, there are a lot of departures from this rule. Why is it sometimes we do better than about half or worse? Well, if it's a study of people who are addicted to heroin, if there is agonist therapy present, like methadone maintenance, they tend to do better than about half. You get more people with positive outcomes. If the follow-up is shorter, in other words, if we're assessing people closer to the end of treatment, the outcomes are better than if we're assessing them far away, which is just what you would find in any other chronic disease. If we use a strict outcome measure, like we say abstinence has to be perfect abstinence every single day, every substance, then we get a lower level of effect if we say abstinence is just their primary substance or we allow 1 or 2 slips. And then last, if you're working with patients who have more comorbid psychiatric problems or more other types of problems, medical problems, economic problems, the outcomes tend to be getting worse. Surprisingly, the type of counseling, in other words, the type of therapy, is it cognitive therapy, is it behavioral therapy, is it psychodynamic therapy, doesn't end up mattering very much for predicting outcome. What about other problems? Generally, when people come into addiction treatment, as you know, they have other problems. They may have mental health problems, job problems, medical problems. And one assumption is all these problems are addiction related. In other words, if you stop them from using drugs and alcohol, those other problems will go away. And in general, that's not true. You see improvement in those other problems, but they have a life of their own. And again, this is actually not a bad thing. This is true about other types of health care. If I have a heart attack and I go to a cardiologist and the cardiologist saves my life, I don't say afterwards, that wasn't a good cardiologist because I still don't like my job. Or that wasn't a good cardiologist because my wife and I aren't getting along. We don't expect healthcare to transform all phases of people's lives. We expect it normally to make an impact on the disease they came to care for. And substance use treatment does that. It can't be expected necessarily to resolve every other problem that people have. All right, now let me just move here, and I'm going to close with criminal justice settings. All the treatments I described, which are administered in the healthcare system with voluntary patients, can also be done in criminal justice settings. But there's an additional model that is important that can only be done in criminal justice settings because it relies on the control of the person as an alternative to sentencing, which I'll explain. Normally, in criminal justice, when someone has a drug or alcohol problem, their experience of interacting with the system, whether it's police or judges or jails, is that the system punishes them in ways that are unpredictable and seem unfair and come far away. In other words, maybe they commit a crime on drugs and alcohol and then 3 months later they're sentenced and then they get a punishment. And they end up not learning how to change in that setting. And what most people need to change, any of you who is a parent will know this, is they need things that happen soon after their behavior, an immediate consequence. If you want your child to clean up his or her bedroom, I'm sure you don't say, if you don't clean up this bedroom, there's a 40% chance that a year from now, I will ground you for a decade. You do something immediate and simple. You say, if you don't clean up your room, you won't get to go to that movie with your friends tonight. That is a much more modest punishment, but because it's swift and it's certain, it's more likely to motivate your child to change. Well, adults and children are the same way. We're more motivated by what happens immediately after our behavior than much later. These programs give us that immediacy. Almost done. Can you advance the slide for me, please? Thank you. So, one of these programs, and I'll just do one of these models for the sake of time, is called Hope Probation. And this has been used for people who have problems with drugs and commit crimes and are now being supervised by a court. So, at the beginning of their supervision, a judge says to all of them, I'm going to explain to you how probation works because I want you to succeed. What is going to happen is you are going to be randomly tested for drug use. You're going to be called in and you're going to have to submit a urine sample. If it shows that you've been using drugs, you will be arrested on the spot. Not later, that moment. And you will be held in jail for a night or two. And that is all. That's not a very serious punishment, but on the other hand, it's swift and it's certain. The judge also says if you get called in for a test and you don't use drugs, then you can go, which is an immediate reward for your behavior. You didn't use drug use, therefore you don't have to suffer any penalty. You can just keep going. This is a randomized clinical trial of this type of probation versus other types. The dark blue is hope probation, where the penalties come swift and certain, and the light blue is controls, meaning people assigned to regular probation, which is kind of unpredictable and disorganized. And you can see positive urines means way less drug use in the hope condition. The likelihood of another arrest is way lower. And then the likelihood of having parole revoked, and what that means is the court says, you're so hard to supervise, I'm sending you back to prison. That's what parole revocation means. Again, much less likely. This is essentially applying techniques, behavioral techniques from the treatment world in the criminal justice setting, and clearly have a very large and beneficial impact. Now, for the sake of time, I'm going to skip the other example and just to sort of sum up my key points. So, people who have serious problems with drugs and alcohol sometimes will come in voluntarily into the healthcare system where they should be provided a range of treatment options. Everything from treatments involving medications, inpatient treatment, outpatient treatment, as the person needs and wants. All those should be available as well in the criminal justice system where many people will come into contact, particularly those who are using drugs that are linked to violence. At the same time, in addition to those treatments, we should be able to use the criminal justice system to do further interventions that we can't do in healthcare, where we structure things in such a way that a person can learn a new way of living, such that whenever they use substances, bad things happen. Whenever they don't, good things happen. And when they experience that over and over again, they're more likely to change and live a different life. Thank you for your attention.